Hi there, Claire Cantro here with Spread the Well, and I would like to discuss something that I think should be super helpful to lots of people and provide a little clarity on this specific diagnosis, and sort of piggybacking on the discussions we've had around itis. And we had a video on tendonitis, bursitis, and today I wanted to talk about arthritis. Okay, so I think this term is used quite a bit, and even sometimes when what's actually happening in the tissues is not specifically arthritis. So again, going back to what does itis mean? Well, it's inflammation of. So arthro is joint, so inflammation of the joint, okay? And what's, the first kind of take-home message that I want everyone to truly understand is that arthritis does not equal pain. Okay, so that's a super hard concept, but I've kind of plugged in some of the pain is complex, tidbits in previous videos. But if you have joint pain, if you have a joint that has been problematic or painful, that does not automatically equal arthritis, right? And the other really important message is that at some point in our lifespan, arguably, people say, well, after 50, arguably mid-20s to even 30, our joints, our system begins to break down a little bit. That is the natural progression of like how much miles, how much weight, how much effort and, reps we've put on our joints. The natural progression as we age is to those joints are going to change. They're going to break down. They're not going to be quite as robust and quite as fluid filled and quite as supported and all of those things as we get older. But that does not mean that every single person with arthritis will have pain. Okay. And that's a hard concept and a hard pill to swallow. And the example that I give is I'll have patients that, come in and, I just assumed that I had raging knee arthritis and bone on bone. And then I got, imaging and it didn't show that. Like, the image said mild degenerative changes. And so the recognition that, what that term arthritis and joint breakdown, which we all have in lots of different areas in our joints, does not automatically translate to pain. So pain is our experience that our brain and our system produces when we suspect that something happening in our body is dangerous or is threatening. So there are some of us walking around out there with disc, bulges and herniations, with bone on bone or moderate to severe arthritis or meniscal tears or, hip labral tear. There are lots of things that so many people are walking around with and that are asymptomatic, right? And so what is it about the people who end up, their systems recognize something that's happening in the joint or in their system as threatening that it needs to create some pain experience so that we start to listen. So, pain is our alarm. It's alerting us to say that something in your tissue or something in your environment may potentially be threatening. And my brain decides, oh yeah, that's something we need to alert her about. So we, stop using that joint, or we get some ice on that joint, or we, start doing things and changing movement patterns to be a little bit more protective of that. Okay. So that first concept of like arthritis means inflammation of the joint and not pain in the joint. The term arthralgia is pain in the joint. Okay. Algia meaning pain and arthro meaning joint. Okay. So, not everyone with arthralgia has arthritis. Okay. And, if you've seen some of my other videos with like, trigger point referred pain patterns and, organic visceral referred pain patterns and all of those things, you can recognize that, sometimes our pain experience doesn't accurately reflect a specific, point where there's pain. So I use this picture as an example in one of the things that I was discussing, trigger points and referred pain. So the rectus femoris, which is one of your 4 quadricep muscles, it's the only one that also crosses the hip joint, meaning that it is active as a hip flexor in addition to being a quadriceps knee extender. The trigger point for the main trigger point for the rectus femoris is up near the hip, and its referred pain pattern is like a raging pain under the kneecap. So people will come in and they're like, there is absolutely no way I don't have severe bone on bone under, this. And I think when you've got a clinician in front of you who understands kind of the bigger picture around pain, then we can look at some of these things that we know, okay, well, I also know that, rectus femoris, I know vastus medialis, I know vastus lateralis, all have some contribution to referring pain to the knee that feels so robustly like what we would describe as this has got to be, bone on bone. It's so significant. And so that's an easy thing to clear out. And 9 times out of 10, I'm not saying that is always the culprit, but we can get some relief by releasing those things. And the reason being is that if recalling other videos that I've been through, if there's some recognition of a potential threat in our system, we have an entire system designed to go into protection, right? So you've got this neuromuscular system that in response to a threat, we're going to protect, all right? We're going to get in fetal position. We're going to be ready to fight, fly, freeze, all of those things. And so what tends to happen, and I alluded to this as well, it's sort of like we have positions of comfort in every joint that our body assumes when there is a potential threat until that threat is addressed or we can dampen the response, okay? So for the knee, that position is in a slightly bent posturing, okay? So if I, without recognizing it, start to change my knee posture, and I go about my day and I navigate my world on a slightly bent knee, and I'm not even necessarily aware of it, but my body's doing this to sort of like, all right, well, this hurts when I do this, I'm going to do that instead. And our body is so good at that, which is amazing, but it's also problematic, right? It sets us up for injury and more problems. So if I'm walking around on a bent knee, that's putting way too much strain and effort on my quadriceps, which have to be active all the time because the extended position is their ability to briefly shut off, okay, in our gait cycle. So if I've got a constant bent knee, then this muscle is constantly active in like an eccentric contraction. That's very hard. Our quads were not designed to do that. So what we end up happening is we get loaded with trigger points, not just in our quadriceps, but if I've got a slightly bent knee constantly, then my hamstrings in the back and my popliteus and my big calf muscles are also like, okay, those are part of that protective dominant system that pulls us into fetal position. So you've got this whole situation happening to sort of protect the joint, and we make an assumption about, okay, my knee hurts. It's got to be bone on bone. It's got to be arthritis, right? And then we're frustrated when we go and get an image, and that image does not support what our narrative is, right? And so I think it's super important to really understand that arthritis does not equal pain, that most of us are walking around with degenerative changes in almost all of our synovial joints, or our joints that are synovial joints are enveloped in a joint capsule and supported by synovial fluid. So like they're kind of in a fluid-filled, system. The other thing I wanted to kind of point out is there are 2 types of arthritis. Well, technically 3 if we add in septic arthritis. But for ease, we've got, let's separate them into 2 things. One is what we call mechanical arthritis. Okay, so that is osteoarthritis. So mechanical arthritis is that the actual joint surfaces start to degrade, right? They start to erode a little bit. You start to get bone spurs. Okay, a lot of times bone spurs form. Well, often bone spurs will form where there's kind of a undue pull or tension at where a muscle or a tendon attaches to a bony prominence. So if we've got this overly inflamed knee tissue and all of those little muscles that kind of attach in and support the knee, well, they start kind of activating and pulling harder and trying to overcompensate to support. Well, they're going to create some bony laydown. So when we pull on a bone, the bone creates osteoblastic activity. It creates new formation of bone. And that first bit of bone is just sort of callousy. It doesn't feel hard like a bone. But over time, the longer it's there, the longer that pull is there that we're not aware of it, it's going to harden. So we get these little knobby things that are happening in and around that joint. The mechanical or osteoarthritis is sort of some of the classifications are that first thing in the morning, these people feel pretty good. The reason is when we're up and walking or weight bearing through those joints that have mechanical, arthritis or osteoarthritis, then we're at the end of the day, you've got a lot of grinding, a lot of, unhappy joints. They're overworked, they're tired. You lay down, you give those weight-bearing joints a little support, okay? Then you wake up and you feel a little bit better, right? And then you start moving and pounding and you get some weight bearing through those. And again, towards the end of the day or with increased activity, that starts to ramp up. On the opposite side, we have inflammatory arthritis, okay? So inflammatory arthritis includes a lot of different, classifications. The easiest one we think about is rheumatoid arthritis or psoriatic arthritis. And the idea is that because of some systemic inflammatory response, right? And this is not where we go into like autoimmune diseases and inflammatory conditions, but when we have, based on our genetic makeup and our predisposition and our family history and all of that stuff, when we have some overly active inflammatory system and that starts to kind of pick specific joints to ramp up, and kind of work through. So we get inflamed joints, and oftentimes inflammatory arthritis is more classified because it's generally bilateral, meaning like, okay, both of my elbows hurt, right? Arguably, we tend to use one side more than the other. So, if it were an osteoarthritis thing, a lot of times we're going to have more breakdown on a joint that we use more, right? But with inflammatory, nothing is safe. So you get this kind of bilateral presentation. Both knees are breaking down, both hips, both shoulders. The other thing is that, and this is an important classification of like inflammation. Oftentimes, these people feel worse in the morning. Okay, so I have a lot of patients who fall into the umbrella of inflammatory conditions, autoimmune conditions, and they feel horrible first thing in the morning because their body has been stagnant for an extended period of time, okay? When our body is not moving, and it's designed to move, and certainly we're also designed to rest at times, but a body in motion means that the inflammation that we have in our body, and we all have inflammation, right? Even someone who does not feel kind of a constant threat of pain or feel inflamed, I know that like if I get sick, if I get the flu or a cold or something like that, and my immune system is kicked on, I'm going to feel achy in all of the spots that have previously had injuries, right? My anterior shoulder, my right SI joint, just that's my classic presentation. You'll start to recognize that if you start paying attention. But inflammation, when stagnant for an extended period of time, gels up. It stiffens, it gets clumpy and sticky in your tissues, okay? Inflammation is pumped into circulation with movement, okay? So inflammatory arthritis conditions feel absolutely worse first thing in the morning after I have a couple of patients, they say I gelled overnight. And then once they get moving, they feel so much better. So these are the people who feel quite a bit better at the end of the day. So now, we've got these two, separate entities. And what I will say is both of these, if recalling sort of sensory processing, and my brain is pulling up messages from what's happening in the tissue, and there is a direct message coming from, say, my knee that's saying, we got some inflammation, we got some breakdown, we don't know what's happening, is this important, should we do something about it? And your brain's like, yeah, that's important. So then we get that protective response. And the way that our body protects an inflamed joint sets us up for more pain. And I would argue that the myofascial and the neuromuscular protective response generates more of the pain that we feel, that because we have these societal beliefs and these narratives that have just sort of, been passed around the medical model and handed down to us, that we assume that arthritis equals pain, right? Or that, bone on bone, right? Or if I'm having severe pain, it means I'm bone on bone. And I think a lot of the times, the pain is way more about the protective mechanism that's happening, okay? And so I'm not going to fix an arthritic joint, but I can help someone go from the person that's being super symptomatic around that arthritis situation to someone who is living with arthritis, with joint breakdown, or normal degenerative changes, without it affecting your life all day long, right? And so, the goal in those cases is to restore balance to the tissue. So if this knee is inflamed, I'm going to milk it. I'm going to flush that stuff out. I'm going to release all of the posterior muscles that are keeping it in a bent position. I'm going to release any trigger points that I think are contributing to our experience of knee joint pain. And I'm going to restore kind of full extension. And once I do that, our bodies know what to do, right? So it's just like sort of helping to point someone in the right direction. So if you are someone who has arthritis and, that sort of thing, is that, that's not a death sentence, right? And I think we have to be better in the medical community about describing to patients what that is. And the fact that this doesn't mean that the rest of your life, you have pain, right? Like that's, we have bought into this idea of I've got arthritis, right? I'm always going to hurt. Well, you don't have to, right? Do you want to not hurt? And so, but again, that means that in the medical community, we are being able to describe things better to patients. We're eliminating fear-based language. It is unhelpful when a physician tells a patient you have the back of an 80-year-old, or, oh my God, this is bone on bone. We got to stop saying bone on bone. In reality, very rarely is that the case, right? And so, we start providing better language for patients, and we start giving them tools to say, hey, you may have a little bit of, degenerative changes. You may have moderate or severe degenerative changes, but if we can create some support around that joint, and we can convince your nervous system that it doesn't have to be so panicked, right? So even if the end result is, this is going to be one of the patients that ends up needing a knee replacement or a hip replacement or whatnot, well, at least going into that, we have set that joint up for way more success post-surgically, right? We have restored a little bit of balance to the tissue. We've not changed the fact that there is degenerative changes happening in there, but we have down regulated and ramped down the nervous system protective response so that your brain can kind of say, okay, well, this is my knee joint. What can I do to continue to use this? And so this started off as an arthritis discussion. And then, and it all goes back to pain. The other one thing that I want to say is, for a very long time, we have described and made the assumption that, based on genetics and my mom and her dad and everybody in the line has had knee replacements. Arthritis is just in our family. Those sort of like connections that we've made. There's a much bigger systemic thing happening when we look at arthritis, and why some people are more prone to breakdown or more breakdown than others, or why some people are more prone to symptomatic, really bigger pain experience, bigger symptoms, more swelling, than others. And so it is not just something that's happening at the joint, but rather a change that's occurred in your central nervous system that has delivered some input or created some sensitized connection to that joint that has ramped up that joint breakdown. Okay. And that's a little bit of a bigger concept, but the important take home is that, like, you can affect a joint inflammation with other things that you do, not just with treating myofascial, neuromuscular, swelling, all of that in that area, but systemically, right? Like, how do I start recognizing what I'm putting into my body that is I'm sensitive to, or that's making me more inflamed, or the fact that my stress resilience, my stress hardiness, my ability to cope, or I'm sitting in a place of chronic toxic stress, and I've got a constant feed forward immune response happening, and that is ramping up my knee arthritis. So I have a when I used to work in the clinic, some of my colleagues would always say, like, Claire can take a simple knee osteoarthritis and turn it into mommy issues. But the key is, there's always a much bigger picture than whatever joint you're treating, whatever diagnosis someone walks in with. Okay. So I hope any of this was helpful as a take home and a little bit better understanding of your joint inflammation and how you can maybe support yourself a little bit better. Thanks.